Is there a test question? Okay, so just to remind everyone that the subject of these questions, the relevant patient population, will be all individuals with either relapsed or refractory Epstein-Barr virus positive, post-transplant lymphoproliferative disease, EBV positive, PTLD, who have received at least one prior therapy. So the first question is the clinical evidence question, which is the current evidence adequate, the evidence that you've seen today, that you've deliberated on today, to demonstrate that the net health benefit of tab-cel is superior to that provided by usual care. Do we have any questions or comments from the voting panel?
Jason, would you like me to do a quick summary of what we discussed this morning?
Yes, we would love that. Thank you.
Yes. So if you pull up, for the panel members, if you pull up your evidence summary, we can just review basically what we have there. In your evidence summary, figures 2 and 3 are showing the survival curves for solid organ transplant and stem cell transplants. These are cohort studies. That's the natural history, which show an overall median overall survival of 4.1 months for the solid organ transplant and 0.7 months for the stem cell transplant group. That's the natural history of the disease. And then we move on to page 9 of the evidence summary that would summarize the clinical benefits. And the objective, just as a reminder, the objective response rate is approximately 50% for both the solid organ transplant and the stem cell transplant as a response to tab-cel. This was in ALLELE, which is the single arm phase 3 study. And then following that, in figures 4 and 5 and 6, these are the survival curves by overall group. In figure 4, the stem cell transplant in figure 5, and the solid organ transplant in figure 6. These are survival curves of responders versus non-responders. So everyone in these curves got treated with tab-cel. And then table 7 are the adverse events that you can review there, which again, there were very few, relatively few serious adverse events. Any questions?
Are there any questions from the panel? I know we had a robust conversation about this in the morning. The other thing I would invite, I know we have some clinical experts. We have our 2 clinical experts. We would love additional comments that you have. We had a robust conversation this morning around randomization and sort of adequacy of evidence. Would love any comments from the clinical experts or questions from the panel. I see Rishi's hands up.
This is just a question for to the 2 experts in this space, the clinical experts in this space. I was just wondering, one thing that, and it relates to the point that was raised earlier about how to think about the people who received the treatment versus the usual care group. I know those curves weren't put next to each other, but one can infer they look very different. Are there any circumstances in which a patient that has this condition would not get the therapy? I guess what I'm getting at again is this question of, are there, everything being the same, are there certain types of patients who would get the therapy and some who would not in clinical practice, just based on severity of illness or anything? Or is this sort of a Hail Mary therapy that's given to everyone who's declared themselves?
So I'll take a first stab at that, and then I'll make a comment. So if you're asking about the therapy being tab-cel, I assume.
Yes.
Right.
Sorry.
And
Right.
that's okay. And so we had clarified that in the prior, not competing treatments, right? Because rituximab and chemo, that would be the first line therapy. So the patients on trial would have failed that. That's my comment. But unlike the scenarios I gave where if you don't have CD20 on your PTLD cells, you can't, rituximab's not relevant, right? Or if you have no blood counts and poor organ function, you can't use chemo. Your question is there a subgroup of patients who cannot get tab-cel? And who are they and how large a percentage might they be, right? So in general, there were
Correct.
trial eligibility criteria, right? But even patients who were on ventilators, if it was thought that their EBV disease was causing them to be that sick, were still eligible to receive the therapy. Similarly, if they had significant organ like liver dysfunction, but it was thought to be because of the PTLD, they could give it because this wasn't necessarily going to make it worse. The question was, were they so sick this wouldn't help? They were unfortunately on their last legs anyway. That's a different scenario. So really the only people who would not get tab-cel in the usual clinical practice are those who are on too much immune suppression for us to think that adding these T cells in, that they'd be able to work in that environment, right? So there were certain prior immunotherapies that were incredibly T cell toxic that were precluded. So for example, if someone had had recent anti-thymocyte globulin or anti-CD52 alemtuzumab, which might be hanging around and would clear them immediately, right? But in general, that's not really the common practice. And I think if you saw an EBV PTLD, as a clinician, you say, oh, I need to avoid those. The other thing that is encountered commonly is these trials, both the registration study and in general across the antiviral CTL field, you do not give these cells if patients are on more than 0.5 milligrams per kilogram of prednisone. So it does require that the clinician and the patient can tolerate reducing that. But if you look at this data and across the field in terms of can they maintain on tacrolimus, on rapamycin, on mycophenolate, other things that both solid organ transplant and HSCT patients are on, that was the case. So really, it's just some rare, really T-cell toxic therapies and high doses of prednisone that rule people out. And we can try to pull them off as quickly as possible, which is what we do.
Thank you. That's a very helpful explanation.
Yeah, no, I agree 100%. One comment to add to that relates to the question of if someone has relapse or refractory PTLD, are there any scenarios where if one had access to tab-cel, that one might consider some other modality of treatment? And that's really unusual. I have to think about case by case scenario, but I suppose if someone's recurrent PTLD involved a very localized area, like a section of the bowel that was surgically removed, then maybe one would perhaps think twice about the nature of subsequent therapy. But PTLD is a systemic disease, so even when you remove that section of the bowel, you still have to be concerned about the need for additional therapy. So yes, in a case-by-case scenario basis, in localized recurrence, that one may decide on what would be the best combination of therapies in those types of selected scenarios.
Thank you so much.
Thank you.
Jason, I think you have a question.
More of a comment, Jason, if that's okay, in terms of how I'm thinking about that question. I didn't weigh in during the earlier conversation around evidence, so I just wanted to sort of share a little bit about how I'm thinking about this. The question before us is the net health benefit being superior, and I'm quite comfortable, very confident that the answer is yes. Making at some point how we feel about the finer points of the ICER evidence rating, somewhat academic, but I still just wanted to acknowledge, that I'm not as confident in the high certainty that the A grade effects of a substantial net benefit, given ICER's own statements about the uncertainties, the lack of comparative trial evidence, the long-term durability not being established, the potentially clinically important differences in subgroup treatment effects, and the additional data needed to confirm the safety profile as quoted there. So I leave open the possibility that those issues could shift, provide new information that might shift the balance a little bit, maybe away from substantial to small net benefit, both of which would still satisfy the answer to the question. So I'm mindful of what we hear often in my day job here from academic administrators about the perils of grade inflation and reserving our highest grade for truly exceptional, unequivocally exceptional performance. This is a positive story, but given the uncertainties there, I think there's a possibility that it might not be as exceptional as we see now. But nonetheless, for me at least, the answer to this question still would shake out as a yes. So I just wanted to offer those comments to associate myself with the comments from earlier today, even with the great clarifications and the hard work of the ICER team.
Appreciate it, and appreciate the analogy. Those of us in academia certainly appreciate the analogy. So thank you. Sounds like you're inclined to vote yes, despite sort of deliberating about, again, the ICER rating matrix has to, as you're referencing, has to do with the magnitude of benefit as well as the level of certainty. Do others on the panel have a different view or an alternative thought process about how they consider the vote? Does anyone want to say anything more about this? Either questions or comments are totally fair game. We want to deliberate as we vote.
Now, Jason, I was just going to say that I think the comments earlier about toxicity and the emphasis, the sort of the minimal toxic effects and the discussion about that was actually really, really helpful. I agree with Jason 1 or Jason 2 that the previous comment that it's pretty clear that this is a beneficial medication. To me, it's just about magnitude, and then the risk benefit calculation. And so questions about magnitude of benefit aside, which we can really only understand the treatment effect from a randomized trial. I think the toxicity discussion was really helpful and informative, because there's clearly a benefit. And so in the absence and with minimal risks to weigh against that, I think it makes the decision a little easier.
Thank you. Appreciate it. I'm sure that we can incorporate that kind of comment and issue in the final report. It sounds like you're inclined to vote yes as well, but that nuance can be captured in the final report as well. Does anyone want to say anything else? Ask any questions of our clinical experts or our patient experts, or just publicly deliberate about how they intend to vote? Okay, I'm not seeing any. So with that, let's move to vote. And I can see that there are 5 votes already. 10 votes. We should have 13 because I think everyone's on the line. And I now see 13 votes, and it's 13-0. So I think given a unanimous vote, I won't ask people to rationalize their decision, but thank you. The next voting question is a question that really has to deal with unmet need. And just to reiterate, this is all these questions are going to have to refer to the same patient population that we had a question about in the first question. And so the next set of questions are to inform judgments of overall long-term value for money. Please indicate your level of agreement with the following statements. And these are questions that are meant to capture things outside of quality adjusted life years that may be important to consider when judging the value of new therapies. So question number 2 is, there is a substantial unmet need despite currently available treatments. And first I will go to Woo-Jung, Dr. Lee, to comment about the shortfalls.
Yes. So I think we have already talked about unmet need in many different ways, and I would highlight that estimating the shortfall is one of the ways to estimate the unmet need. And just to remind everyone, the unmet shortfalls indicate the difference, absolute or proportional difference in the number of life years that patients with disease, so relapsed or refractory EBV positive PTLD, are expected to live under the current available treatments compared to the US general population of the same age and sex. And the absolute shortfall for this disease was 26 years, indicating that the average number of life years that patients with the disease under usual care is 26 years lower than the US general population. Based on the proportional shortfall, it was 89% of the US general population.
Thank you. Joe, I think you have a question or comment?
Yeah, I'm going, I had to remind myself of what our future questions are going to be. So it could be that I've answered my own question, but I'll put it out here anyway. In that, part of what we've talked about when we think about unmet need is not just for the person, right, but for the family that is surrounding the person and all of the judgments needed to get made in the decision-making around, as Dawn brought up earlier, just the decision-making of whether or not there's sort of hope that something could be treatable, and the very high likelihood that you're going to get something like the EBV infection. So I'm just wondering if, from the perspective of, as we consider the unmet needs, how do we balance how we think about unmet need, not just with the very technical definition that we just heard, but also from the sort of quality of life unmet need for both the person and their caregiver. And I know we're going to think about a caregiver question separately, but I'm just wondering if you could, if somebody could sort of think about how we evaluate unmet need, not just in sort of that quality of life calculation, but in the greater scheme of the sort of the implications for hope, toxicity, and sort of feeling as though there's a mechanism by which there's information about whether or not you're likely to be successful post-transplant, because something might be may be available for you from a treatment standpoint for something that is likely to happen, that will severely impact life expectancy and quality of life in that time period.
Yeah, this is such a thoughtful question, and I appreciate it so much. I mean, I can just offer my interpretation of how to consider these questions. So as you're referencing, there will be forthcoming questions about caregivers' quality of life and their own ability to pursue their own life goals relative to the treatment helping their loved ones. There's also a different question around mechanism in terms of relevant to access to care. So something like sometimes if the prior therapy for something is injectable and there's a new medicine that's a pill that may be given in different settings, improving access to care. The question before us, I will say, the quality adjusted life here is really good at sort of showing health status and length of life. So this is really more about the severity of the current circumstances for people with this condition. So I mean, that's at least my interpretation of the questions. There's some questions that we'll touch on this later on, but I'm not sure that the hope concept that Don had introduced earlier in the day is reflected in this question right now. That's at least my interpretation. If others disagree, feel free to speak up. Brian, do you want to go ahead?
Yeah, I mean, just to say that it looks to me like there's a huge unmet need right now. And we're talking about very little treatment for people with refractory disease. So, we're talking about 0.7 months of survival untreated. So it looks to me like there's a huge unmet need right now, irrespective of life years and irrespective of what's happening. I mean, obviously very important life years and family members and caregivers, but there's just not a lot of options right now. So it seems, again, maybe I'm oversimplifying, but it seems like there's a pretty obvious unmet need to me.
No, it's my view as well. Does anyone have a? Oh, I think Dr. Nicoforo, one of the clinical experts, has a point to make.
Yeah, I just was gonna follow up on the caregiver aspect because you mentioned toxicity, and Doug, I think, talked about this as a patient. But some of the other options, especially the chemotherapy-based option, and again, we're talking about people who either have failed it usually or were not considered candidates for it. But anytime you get a really impactful therapy like that that has toxicity, there's significant caregiver needs, right? So most patients who are getting chemotherapy cannot go through it alone. I would not want anyone with EBV PTLD to go through any phase of it alone. But in terms of patients being able to fend for themselves, being able to work through this therapy, that is every expectation, right? So I think as you think of the pros and cons, there's the patient and there's, can patients access this depending on their social support network, right? Which limits, really does preclude in the real world availability of some therapies to patients. And this really has very little caregiver burden as well as little patient burden, because those are tied together. That was going to be my comment.
Yeah, no, that's such a helpful comment, and I would just potentially just suggest to the panel, my colleagues on the panel, that that point may be very pertinent to this later question that's about to come around caregivers' quality of life and ability to pursue their own goals. Any additional questions or comments, or should we move to vote? Dr. Allen.
Yeah, I think I just wanted to comment on the unmet needs, and when we think of the use of Tab-cel, one is thinking of relapse or refractory PTLD. But as we move forward in time, we'll get a clearer picture of whether or not there are some patients who, for whatever reason, are not candidates for a particular upstream modality of treatment, like chemotherapy. And in that regard, the potential pool of eligible patients for Tab-cel would increase, because we do know that there are variations across patients that are reflected in some patients being completely intolerant of certain chemotherapeutic medications, just in terms of toxicity. And so I think it's important to bear that in mind, that it is end of the road treatment, but in some cases, the use of Tab-cel might need to come a bit sooner for some categories of patients.
Thank you so much for that. So I would suggest that we move to vote, unless anyone has anything they want to say. So this is about substantial unmet need despite currently available treatment. So in a hypothetical condition where people already had really good options, you might want to say 1. But in a condition where there's, a really poor prognosis without this new therapy, we would consider a 5 rating. So that's how this Likert scale is designed. So feel free to go ahead and vote. I see 9 votes already. 10, 11, expecting. I have 11 votes, so 12. 1 more. 13. Okay, great. Substantial unmet need despite currently available treatments. 12 of us voted strongly agree, and 1 of us voted agree. And given the marginal difference between the 2, I won't put that 1 person on the spot unless they want to speak up. Next question, please. So the next question is another contextual factor, which is that this condition is of substantial relevance for people from a racial or ethnic group who have not been equitably served by the healthcare system. So maybe Dr. Lin, Grace, do you want to say in your formation of the report, was this a factor in this specific condition?
Yeah, thanks. The number, this is a rare disease and the numbers are small. So it's we don't have numbers that reflect racial and ethnic differences that we know of in prevalence. I will note that there are disparities in access to transplant. in terms of racial ethnic disparities to transplant. However, this is post-transplant, and post-transplant, there aren't any data to suggest that this disease, differs amongst different racial ethnic groups.
Thank you. Any comments from the experts, patient experts, clinical experts, or any other questions or comments from the CEPAC?
Yeah, I do agree. I agree with Dr. Lin's comments. The only difference across at least one difference across groups might relate to the stage at which various individuals present to care with their disease. That it is possible that there are some folks who come much later on as opposed to those who are caught, who are identified much earlier on in their disease. That might affect the nature of the treatment that they require and the outcomes.
Thank you for that point.
I'd just like to add just one quick comment, and that really relates to the cost for people who are from different ethnic groups. If you're covered by insurance plans or in Medicare, it's one thing, but if you're not, then you probably could fall through the safety net. So I'm not sure how that would be dealt with in this situation based on the suggested cost.
Yeah, that's obviously something that's of tremendous interest to our process. This specific question really deals with racial and ethnic groups rather than insurance status, but your point is incredibly important for our entire process. Dr. Nickfro, I think you have a question or comment you want to make?
Yeah, I was going to make a comment, and I had alluded to this before, that in terms of literally an organ transplant, this is easy to get, right? So my hope is that any patient, if this is FDA approved, would be able to access this at their transplant center, right? I think that's the ideal scenario, especially given the risk-benefit profile, and I would say the relatively restricted resources that are needed to deliver this as opposed to some other cell therapies. I do think, though, that falls on the company, and it's an interesting question of how widely do you distribute this? In general, again, I'll go back to the chimeric antigen receptor T cells, were only opened at 30 or 60 centers in the nation, right? Because they have such a high toxicity profile, and the manufacturers wanted to make sure that things could be delivered safely. So I think one of the questions of access is, what is the manufacturer planning to do? Where did they feel the risk benefit lies? My hope is, because the toxicity is so low, that this can be broadly used at the centers where patients are having their transplants. So that was one comment. Then in answer to the financial piece, again, I can only draw from other cell therapies. And I think that when you talk about delivering a cell therapy, my mind immediately goes to, can I give it to a patient, what needs to be done? But there is a backdrop of resources that the institution needs to invest in terms of negotiating with payers and getting insurance approval prior. And believe it or not, I feel like that takes even more work than getting the patient into the hospital and getting the cells into their vein, right? And what happens, in my not well-informed perception, is that if you are not Medicare or Medicaid, the institution may need to draw up an agreement for every single patient, right? And actually, in the CAR space, we are trying to tackle some contracting and make it more transparent and standardized so that that process can be easier. So I'm not sure that is anything that ICER would have jurisdiction over, but publicly indicating that that in itself can be a barrier to access in terms of how much an institution needs to invest to allow everyone's insurance to be negotiated with is a valid one.
This is such an important issue, and I would love to discuss this more in the policy roundtable, because this will be central to our process. So hold for the policy roundtable, because we'll have to talk about that more then. So the question before us again is around race and ethnicity. So the hypothetical example is if we were considering sickle cell, which we're not, that's disproportionately affecting Black patients who have not been historically equitably served by the health system. At least by my ear, I'm not seeing that or hearing about that for this specific condition, but just to be clear about what this question is getting at. So, if it were sickle cell, hypothetically, you might vote 5 because, because that to sort of draw out that inequity. This, at least I'm not hearing, there's not a clear race or an ethnicity association with this particular condition. Are other comments or questions from anyone, or anyone disagree with what I just said? By hearing none, let's proceed to vote. Three votes I see, 7, thank you. 9, 10, 12, 13. So I think we're done. Okay, so 4 strongly disagree, 4 disagree, and 5 neutral. And the ICER is always thinking about how these questions are worded, and I would take all of these as that there's not a clear race or ethnicity predominance that's relevant to this specific disease condition. Next slide, please. Next question, please. So again, this is contextual. We're trying to inform in ways that we haven't captured through the economic model our assessment of long-term value for money. And so the next question is whether the treatment is likely to produce substantial improvement in caregivers' quality of life or ability to pursue their own education, work, and family life. And I think some of the comments we were getting into before may actually be very pertinent to this. This is meant to capture, which is not something that's captured in the qualities, that maybe a new treatment really helps the patient, but also may help the people around them who have a great burden of caregiving. So we've touched on that a little bit already, even in the discussions now, but does anyone want to say anything about this? Any of our experts or anyone from the CEPAC? Questions or comments from anyone on this? Grace, do you want to say anything about this?
Sure. So I think actually I would defer to our patients who have firsthand experience about what their caregivers went through, and so would our patients like to comment on the caregiver burden of caring for someone with PTLD?
Yeah, I'm happy to share. I think, no, you've been naming the ripple effects throughout a family and friends, and I'd be interested. I guess the thing that was coming to mind was the cost of even a stem cell transplant. That's like an allo stem cell transplant. How much, not just that costs, but that happens in the hospital, staying overnight for months, and versus the tab cell, which can be given outpatient and low toxicity. So I feel like there's a lot of ripple effects. The impact of something like an allo stem cell transplant that aren't in something that like tab cell. Seems like something that would be very would help the family because of that, and the family wouldn't have to. My family had to move where we were in New York and during the transplant, but then I think with I was in a situation where I still had to live there a little bit with tab cell, but I think some patients are able to be outpatient, and I think I can't speak to other experiences, but certainly I could see where it'd have the whole process is an enormous lift on families, and it seems like outpatient tab cell would be a less lift. Would be my just quick thoughts.
Yeah, that's exactly what we're trying to get at. That's such a helpful comment, because that's exactly the concept that this question is trying to get at, is whether the therapy would have these ripple effects, as you're saying, on family members. Do additional people have questions or comments about this? Rebecca?
Just a quick comment and maybe a question in the context of pediatric patients, which is one of the likely patient scenarios as well. I would think that the parent lift, comparable to what Doug just spoke about, would probably be substantially reduced in this context, but I was interested in the clinical expert's perspective there, just to make sure that my hunch is in line, just so that we're considering the pediatric part of this as well.
Yeah, I'll defer mostly to Dr. Allen because I treat adults, but I can only imagine that this would be much better tolerated and easier for the families in general because of toxicities. And then Dr. Allen, sometimes our adults have big enough veins that we can get in peripheral IVs, right? But often chemotherapy needs to be given through surgically implanted lines, which I think are much harder to manage in children than they are in adults. And at least in my adult population, Tab-cel can be given through a peripheral IV in most of the patients that I see, right? So I think there's so many aspects in which, again, we're not comparing. Most of these patients either already failed or had the therapy fail them or haven't had access to. But I do think that this is, especially in the children, less of a lift.
Yeah, I agree 100%. So from the perspective of the child, I agree. Not having to be administered through a central line, an indwelling central line, is a major benefit. There's a risk of having central lines including, and get complications such as infections, right? So if it can be administered through a peripheral IV, that's huge in terms of the benefit to the child and to caregivers as well, and in fact those healthcare providers as well. And then we certainly recognize the burden that families face when their kids have to undergo chemotherapy. It's a big deal, and so definitely there's that perspective, and if Tab-cel is associated with less toxicity compared with chemotherapy, you can see how overall that's a net positive from the family's perspective as well.
These very helpful comments are pertinent to the question before us, but also the next question will be about mechanism of action and sort of accessibility and access. So I think these comments are incredibly helpful for both of those questions. Dr. Lin, I think, Grace, do you have a question, a comment?
Yeah, I just wanted to reiterate, I think this point was brought up earlier, but Tab-cel doesn't require pre-treatment as some of the other treatments do. So for example, for some treatments, the CAR T, you have to undergo bone marrow conditioning. So you have, treatment with a toxic drug beforehand, and which also lengthens the treatment. And the other thing is, because Tab-cel is off the shelf, so for example, for the CAR T therapy, you have to harvest the cells from a patient, send it to the manufacturer, who then processes it and then sends it back to be administered. So that can take weeks. Whereas here, I believe that if there's a match, that the treatment can come to the patient in a few days. And so that length of time of treatment, which Doug was also alluding to, like you have to move your family, you have to stay in the hospital, that with Tab-cel is much.
No, thank you so much. That's incredibly pertinent to this question, so thank you for raising it. Does anyone from the voting panel want to comment about their thoughts about what they intend to vote for the others to hear? I sort of detect the theme, so I kind of see where this is going, but would love anyone to be explicit about it. Julie, do you want to say something?
There we go. Sure. When I was reading this question and I saw specifically that caregivers' quality of life was called out, that made me think a lot about what we've been discussing in terms of how this drug is tolerated and the low side effects that patients are experiencing. And I think there's such a correlation between caregiver quality of life and patient quality of life and how that impacts a caregiver. So I think having a patient take a drug that's so well tolerated may actually help to improve a caregiver's quality of life, seeing their loved one not have to suffer through the side effects that they may otherwise be experiencing with other drugs.
Yeah, no, thank you. That's a great point to make. Don, do you have something you want to say too?
Yes, there is no doubt in my mind that this medical condition imposes a substantial burden on caregivers. But I am stuck with my proclivity for literalism. And I listened to Dr. Allen a minute ago say that there was a net benefit, but the question actually uses the word substantial. And so, from a lawyer's perspective, if you tell me that something is true by a preponderance of the evidence, that's 51%. That's less than substantial improvement. And I'm not sure I have been convinced or persuaded or convinced that there's anything other than an incremental improvement. And that's not substantial in my mind. Sorry to be a literalist.
No, this is why we value attorneys on our voting panel. So thank you. Yeah, no, I mean, I'm not sure I agree with you about how I'm probably going to vote, but I do agree with your interpretation that the substantial is a interpretable term, but really references the meaningfulness of the magnitude.
Well, I'm struggling with the fact that in every one of these deliberations, we're dealing with diseases that are awful, that impose significant burdens on people who live with these diseases and people who love the people who live with these diseases. And I don't want to just express that by clicking on strongly agree with every voting question that alludes to those challenges that these diseases impose on people.
Yeah, no, I think it's a very thoughtful point. Joe, do you want to say something?
Yeah, well, thank you, Donald, for making the point. I was thinking the same thing. This is only my second ICER panel, so in the last one I was at, I don't think delved into issues like this. So I wasn't quite sure. I was more listening here. But it strikes me that there's not actually any evidence to guide this decision. We're basing it on our, thank you to the clinicians who care for these patients who are providing their experience. But, there in some, there would be examples, for instance, like in the Alzheimer's disease literature, where you would actually have there are caregiver burden measures that it would be collected as part of research studies to better understand the impact, as opposed to just anecdotal determinations. It's very hard for me to strongly agree or disagree in the absence of evidence.
Yeah, no, I'm health services researcher too, and I totally see where you're getting here. I think that in the absence of evidence, I think it's reasonable to sort of, I don't want to say guesstimate, but sort of make assumptions about likelihood. And it may be that there's not sufficient evidence in your mind to alter your probability of that occurring. But as a general matter, we're more permissive about anecdotal evidence in this particular question, although I agree that sort of more study of caregiver burden would be informative. Dr. Nikiforou, do you want to comment?
Yeah, I was thinking less caregiver, but if we focused on the patient, and I agree with you that sort of patient quality of life reported outcomes would be tremendous here, right? Which we don't have. I think the cell therapy field is catching up. But if I were to have metrics, which I don't, but let me propose some. So if I could say how many patients receiving, again, it's not comparison, it came before and they have no other option, but so really we're comparing to nothing, but let's say I took CHOP. What percentage of patients need a central line to get CHOP versus Tab-cel? I think you would have wildly disparate numbers, right? What percentage of patients require hospitalization for complications of chemotherapy/CHOP versus Tab-cel? I think you'd have widely, substantially, statistically different numbers. How many patients need additional medications like Neupogen or Neulasta to support their blood counts with these therapies? It is going to be 100% with CHOP in the adult setting and 2%, right, for tab-cel? How many people need supportive, prophylactic acyclovir, Bactrim, just all these other things that go along with it. So what I'm trying to do is, yes, I'm trying to convince you, but I'm trying to say that part of my and Dr. Allen's perception does come from discrete aspects that are needed or often entailed in one scenario that are not in another when treating lymphoma or PTLD. I think maybe that helps a little bit with why we feel more comfortable saying it's substantial, that you can't see without us articulating it.
Yeah, no, and those comments are incredibly helpful and informative. These, some of those things obviously will be picked up in the economic model, right? In the comparison between therapeutic pathways, but here we're trying to capture the things that aren't captured in that model, some of which are relevant, as you're saying, especially as it gives to the family members, caregivers, and their own priorities in education, which are things that are not affected, not encapsulated by the quality adjusted life year. I am going to move to Dr. Agboola, but I first actually want, Mr. Worthen, do you have a comment? You looked like you did, but you didn't have your hands up.
I just want to add, like, my mom's quality of life was substantially improved by me being alive. So.
No, I think any of us who are parents understand exactly what you mean. So we appreciate you saying that. Dr. Agboola from ICER.
Yeah, and I think the comment I was going to add, I think Dr. Wasfi just said it a moment ago, was just the whole point of this section of the vote really is that we can think outside of some of the things that we may not, that are not fully captured by the clinical evidence or the cost effectiveness analysis, because we know that there may be other benefits that have not been well quantified. And the other aspects of the therapy that Doug has spoken to and the clinical experts have spoken to, that we know a drug that works is likely going to be offer improvement for the caregiver, but there may be other aspects of the therapy, maybe by its delivery or the less toxicity, that is able to help with that improvement. And that's some of the things that we're hoping that this vote will help to capture. So hopefully that's helpful, particularly for Dr. Ross, who is relatively new to the process.
No, thank you. It's the point I was trying to make too, but I think you did it in a much more succinct and eloquent way. So thank you. Rebecca Kirsch.
Thank you, Jason. I just wanted to make one last point, and you all can course correct me here, but one aspect that isn't discussed and we haven't hit on is oftentimes the caregiver may be the donor as well, solid organ transplant or otherwise. And I want to make sure that we're very clear here that I'm inclined to recognize the substantial improvement for those who were the donor in either context for this patient, and what it means for them that the outcomes have the potential to be favorable as a result of this treatment. I think that's an important consideration that's outside the usual context of when we think of patients and caregivers here. There's that third element.
Yeah, that's a great point. Thank you for making it. So with that great conversation, let's move to vote. And I just want to say, I know we've said this a couple of times, but so the pertinence of this question, there's all sorts of topics that are really important that are dealt with by different aspects of our voting process. This is the question that deals with family members, caregivers, their own ability to live their lives, to do the things that they want to do, and how this medicine being given to their loved ones may affect that. Because we're trying to capture things that are not in the economic model, in addition to the economic model. So feel free to vote. I see 9 votes, 10, 11, 13 votes. So I think we're done. Okay, great. So 2 neutral, 6 agree. I voted agree. And 5 strongly agree. And I would, at their discretion, feel free to stay silent if anyone in the neutral camp wants to talk about their vote and why they voted that way, so we can capture those thoughts. Don.
Well, I was one of the two neutral votes, and I already explained myself, I think. So it really has to do with the word substantial.
Yes, no, that's very helpful, Don. Thank you. Joe, do you want to?
Yeah, I was the same, and I would just note that I interpreted this as really disentangling from the outcome that the patient experiences from the treatment. It's about the burden of the treatment and the role that the caregivers play in it, and that word substantial.
Yeah.
Yes, I would chime in and say that's true for me as well. I acknowledge that a caregiver's quality of life improves substantially if their loved one doesn't die. That's obvious.
And does anyone else want to talk about why they voted for either agree or strongly agree? You don't have to, just if you want to. Okay, seeing none, I will move on to the next question. So this is, again, the same population. The treatment offers a substantial opportunity to improve access to effective treatment by means of its mechanism of action or method of delivery. So that's, for example, a hypothetical example of that would be, let's say a therapy for something is only given in academic medical centers in 3 cities in the United States. And then there's a new therapy that you can pick up at CVS and take it home. You don't have to travel to those 3 cities. That hypothetical example would be massively improving of access, so that patients in rural areas, patients in different cities would be able to get access to something that they would not have access to otherwise. And you can see in that hypothetical example, that's not the kind of thing that would be captured in the economic model inequality. So that's the kind of thing we're getting at here. So would love to hear any thoughts from Dr. Lin first, or any of our experts.
So thank you. So, this is and I will defer to the clinical experts, but I think we have talked about the fact that this is a new, cytotoxic, even though what's new for PTLD, but that the cytotoxic T cell therapies have been around for a while. But the delivery of it and the process of it is what's new, that it's off the shelf, that you don't require that long turnaround time, and that people have quick access to this medication.
Thank you. And Brian, I think you have something you want to say?
Yeah, I would love some more clarification from the experts, because we keep hearing the term off the shelf, but I don't think this is quite like off the shelf at your local CVS. There's still a fair amount that goes into get the HLA typing and make sure the EBV expression is an antibody is appropriate. So it's not quite off the shelf, even though that term's been used a lot. I'm also not clear. At one point, I got the impression this could be given at almost any hospital, but then there was one of the experts mentioned it would be at the transplant center. That's not increasing availability as much as I would think a really highly available therapy that could be given in a local community hospital might be. So I'm a little unclear as to both those points, off the shelf and ability to give it in places that are close to where the patient lives and not requiring travel to a transplant center.
Yeah, Dr. O'Sullivan, those are great points, and I'll try to address them. So one is that when patients, because remember, these patients have been through a transplant, right? So that typically for my patients, I'm a stem cell transplant physician. Literally, all I need to do is open a folder in the medical record, print it out, and send it in, right? So you do refer to a step that can take time. It's already done though, right? Because these patients and their donors have been through a transplant. Similarly, to make the diagnosis of EBV PTLD, you actually do both imaging and blood work, so that you've gotten all your things assembled by virtue of your prior workup to establish the diagnosis and the prior transplant, right? So for these patients, that's already done. So in general, you will send the information in, and it usually takes maybe a day or two to be able to look through the bank, which is in general well codified, although don't work, right, for Pierre, Febvre, or Atara. But in general, it's all codified. They can look through, and they've already characterized the EBV antigen presentation so that it is actually a fairly easy process to make with information, a decision to make with information you have at hand. And then what's sent out are vials, right? So those can go easily in the mail, and there are qualified shippers of various forms of cellular material that can be used. On the flip side, the question is, where will these be administered? So there's the question of where could they, and where do I think they may be, at least to start? So you need to have an area where you can, and I would say that almost any designated cancer center, right? Big caveat, or major medical institution could invest and get this up to speed easily. But you need some place to store cells that is monitored. So God forbid the temperature goes out, right? Someone can respond to it and you know you're getting relevant material. And you need a place that can take from the vial into the syringe and do that in a sterile fashion, right? So does that exist at every single community hospital today? No. Does it exist at every transplant center? Yes, right? Does this, though, require a significant amount of infrastructure to imagine that it could go out to the community in a hub and spoke model? The transplant center would have to remain the hub because they have all that information that you just asked about, but they can obtain it easily. And in the other cell therapies, again, like CAR therapies, for instance, UPenn, which I'm not at, is the hub, and they work with their community cancer centers, right? So I think you raise a great point that there is going to be a ripple of expansion as we roll this out. And I envision the accessibility would be very different a year from now than 4 years from now. I hope that makes some sense.
It does. Thank you so much. Joe, do you have a question or comment?
Yeah, I just wanted a clarification. And I think it was patient side who spoke to this. So can we just talk a little bit about the tolerance component and whether we're thinking about that being part of this conversation too? So this alternative treatment, I think that's okay if I call you Doug. Doug really did talk about sort of the difference between being able to take this and not have this sort of massive side effect profile that comes with some of the chemotherapy alternatives. And so in my mind, I'm wondering, when we think about, you know, improving access to effective treatment, how we contemplate the tolerance component of this.
I think it's obviously an important issue. I think my view of the interpretation of this question before us, obviously this is a critically important issue, but that kind of thing we would expect to be captured in the economic model because it's a comparison of A versus B. So while a tremendously important issue, it's not what this specific question is meaning to get at. That's at least my interpretation. I don't know if anyone from ICER agrees or disagrees. I saw another hand up. Did I?
Well, Jason, that was mine. I was just sort of spinning around the issue of how to interpret this question in terms of improving access to effective treatment. If we all agree this is the only known effective treatment, but I'm realizing now that this is really about mechanism and action or method of delivery as the sort of novelty of it. That's right.
Exactly.
Yeah.
All of these issues are important. This specific question is very circumscribed and pertinent. And again, all of these questions you can see are trying to get at things that we haven't talked about earlier in the day or pertinent to other votes. This is really about the mechanism of action. So there was that example that I gave about the 3 highly specialized centers giving a therapy. If you could switch it to a CVS medication, that would obviously tremendously increase access. Another example might be, for example, if the prior therapy for something, actually this may be pertinent in this setting, is IV only. Perhaps there are people who are afraid of needles who would be avoidant of such therapies, and a new therapy that does a similar thing that's oral, let's say hypothetically, they're just as effective, so they probably would fail the comparative evidence vote. That would still be a real help to those individuals who are scared of needles. So it's that kind of issue that we're trying to get at with this question, if that makes sense. Brian?
Yeah, and not to perseverate too much, but I think what Sarah said is really crucial, is what's going to be available now versus what's available 4 years from now may have a lot of import on my response to this question, because I'm not sure it's going to be super available right away, but a couple of years from now, it may be widely available. And I guess just like price, we don't know that right now. That's an unknown.
Dr. O'Sullivan, I'm sorry to interrupt. I'm going to say one more thing. My stem cell transplant patients have to come back and see me every week for the first 3 months, right? And then after that, it may space out, but it all depends on how you're doing. So I think that I know how closely the organ transplant patients are followed at their transplant site, right? So I think that's why I may have a perception that it's less limiting, because they already have to come there anyway as transplant patients. You know what I mean? So I think you have to take the starting population into account, that you've already got a group that has the wherewithal, the social support, the financial support to get to a transplant center, right? So I think that's a little different than it being available to anyone in the community. You're dealing with a select starting population.
I think also Aaron's connection is bad, so he's asking me to ask. I think there's a lot of interest in this question of future infrastructure versus current infrastructure. So would you say that tab-cel it would increase access with current infrastructure? I've never really struggled with this before, but for this specific question, I think we mean current infrastructure as opposed to any future
Yeah,
change.
so I think with the current infrastructure, my sense is that transplant centers, certainly stem cell transplant centers, have the capability to store and deliver cells, right? So that's a given. And I would say that any organ transplant center likely already has a lot of the infrastructure to just be able to receive, store cells temporarily and get them out to the floor, right? So again, starting from the population that is already required to visit these centers, I would think that they have the infrastructure to do it. And compared to other cell therapies, the infrastructure required to deliver this is very, very low.
Thank you.
Yep.
Let's move to vote. So you have 5 choices here: strongly disagree through strongly agree, about improving access to a treatment by means of the mechanism of action or method of delivery. So it's circumscribed to that issue. See 5 votes. Ten votes. We have 3 more. 12. Missing 1 vote. If anyone's having trouble voting, let us know. 13. Thank you. Okay, so 7 agree, 4 neutral, 1 disagree, and 1 strongly disagree. No strongly agree. Okay, so that's great. So we've had such a robust conversation about this. I won't call on people to sort of explain their rationale, because you all have done it very well already. So with that, I think the next vote normally would be a value vote, but you can't vote on that if you don't know the price yet. So in the setting of the price not being available yet, we will not attempt to take a value vote. So we will, I think Dr. Nikiforou wants to say something, and then we will move to break for 10 minutes. But first, I'd like to hear from Dr. Nikiforou before we leave.
Yeah, and I'm not trying to query any vote at all. I just think it's interesting. Grace and I have both mentioned CAR T cells, and I'll tell you why I'm going here as the example of you have to send it out, wait for manufacturing, come back. When I started my PhD in this field 25 plus years ago, that's actually how this therapy was given. If you had a PTLD post liver transplant or stem cell transplant, we would go back to your original donor. We would harvest cells from them. And at the beginning, it took over 3 months to get a product, right? So as I try to explain why I think, oh my gosh, this is such an improvement over what we have in other cell therapies and have had in the past, I think that the allogeneic bank aspect, if you understand the history of where this came from, is a bit revolutionary. So not trying to influence any votes, but just explaining how far the field has come.
No, that's wonderful to hear, and you should absolutely feel free to influence votes. This is all discussion and deliberation and being open, and we welcome all perspectives. We welcome all perspectives and expertise, and we're so grateful that you're here with us. So with that, we have about a 10-minute break, and we will come back to the policy roundtable. I know you've had some previews of some of the interesting things we're going to discuss about already, but we'll get much more into it. So see you all in about 10 minutes.